Order, order. Welcome to today's session of the Health and Social Care Select Committee, which is on the work of NHS England. Welcome to our witnesses. May I start by asking them to briefly introduce themselves, starting with Duncan Burton.
Yeah, morning. I'm Duncan Burton. I'm the Chief Nursing Officer for England.
Thank you. Amanda Pritchard.
Amanda Pritchard, I'm the Chief Executive of NHS England.
Julian Kelly, I'm the Chief Finance Officer for NHS England.
Thank you very much, and thank you all for joining us in the first of hopefully many appearances in front of the committee to talk about your work. Now, Amanda, you'll have seen today that the Public Accounts Committee has published a report that questions whether senior officials in the department and the NHS have the ideas or drive to deliver the government's 3 shifts and realise the transformational change they feel is necessary. May I invite you to respond to that report?
Thank you very much. And I would say there are a few points raised in the PAC report that it's really helpful to address. I'm sure you may want to talk more about it during this committee hearing. I should say, of course, we will be formally responding to the PAC on the factual inaccuracies within their report. But firstly, I would like to say NHS England is absolutely not complacent about productivity, and it is completely wrong to suggest otherwise. While NHS productivity is now improving at double the rate it was pre-COVID, there is still a gap from where we are now to where we were pre-COVID. And far from being complacent about that, we have been repeatedly open about the challenges and our plans to address it, whether that's in committee appearances, in the media, in every public board meeting that we have, and we will be publishing further improvement measures in planning guidance tomorrow, or hopefully tomorrow. On earlier budget allocations, of course, everyone in the NHS would like to see earlier budgets, and the earlier that we can give NHS colleagues their allocations and operational priorities for the financial year ahead, the better. However, if I just quote Julian and what he actually said during the PAC appearance, we clearly try to give, this is me quoting you, early informal indications of what people should be expecting, but we actually need to know what our budget is in order to be able to give a budget. So I think it is worth just saying that NHS England's planning guidance for the NHS, alongside ICB financial allocations, is subject to cross-government clearance, and that's an important principle. It's important because the NHS budget is billions of pounds, and therefore understandably has to be subject to proper engagement with ministers, and that is not just in the Department of Health. That has to be across government, because these are really difficult decisions for government. But as soon as we have cross-government clearance, we have released planning guidance, certainly in the last 2 years, that same day, and we're planning to do so hopefully again tomorrow. There is a suggestion in the PAC's report that the shift to community has stalled. Now, obviously, that shift to community was hugely disrupted by the COVID pandemic, but that is why, far from stalling, NHS investment in primary medical care and community services increased faster than overall ICB spend in 23-24, and this year we in government have put in additional funding for primary care to enable up to 1,000 extra GPs to be recruited at PCN level. Finally, to your initial point, I would just say there is no shortage of fresh thinking in the NHS. At the moment, we are working really closely with government to drive that innovation forward as part of the development of the 10-year plan, which is going to be a really ambitious plan to build an NHS fit for the future. But really importantly, I would just add that nobody is waiting for that to get on with the job of delivering reform. So as the Secretary of State has said, these shifts are not radical new ideas, but actually delivering them, of course, would be. So in advance of the 10-year plan, we have, for example, set out plans to go further, both in building on existing initiatives and in radical new ways. So, for example, the recently published elective reform plan sets out how we will provide more convenient care closer to home in the community diagnostic centres that we've been establishing over the past few years, and how we will transform patients' experience of care through the use of the NHS app.
Okay. I used to sit on the Public Accounts Committee. Saying that the report is full of factual inaccuracies is a bold claim. May I invite you to also write to the committee about that? But may I also, just what they are, because I also take umbrage with the quote that was put out by the department suggesting that Parliament, not that committee and not that report, but Parliament as a whole, quote, does not understand how the NHS is funded. Now, putting that out the morning before you appear at the Health and Care Select Committee, again, I would urge, is rather bold. So I wonder if you might want to retract that particular wide statement. Absolutely, you have every right to respond to the Public Accounts Committee and how they might have interpreted the evidence given before them. But can we start this session on a foot that perhaps suggests that we've got a level of knowledge and it might not be the entirety of Parliament that doesn't understand how the NHS works?
Are you referring to a quote from the Department of Health and Social Care or a specific quote from NHS England? Apologies, I haven't got it in front of me.
It was the quote that we saw in the HSJ, wasn't it? Yeah, forgive me, I don't have the...
On a personal level, let me be clear, all of the comments that have been made by NHS England refer specifically not to the NAO report, but to the report from the PAC. Yeah. And we will be writing to them as soon as we can in an appropriate way, just to go through the factual issue. So no query at all with the NAO's report, but I think there have been clearly some examples where the evidence of the NAO report and the evidence from the session have not been reflected in the report, and those are the things we'll be writing to the committee about. In terms of understanding how financial flows work, my experience over the last few years is that people are hugely knowledgeable within Parliament about that, and I'm sure we'll get into more of that detail today.
Yeah, we're very keen to. And please, would you commit to writing to us as well when you respond to those financial inaccuracies? Thank you. Thank you for responding to that report, and we will be getting into much more of the detail of much of what's in it, but also more. And I think you started by talking about the 10-year plan and the 3 shifts, and you pointed out that it had stalled and COVID was part of it. But we do need to do things differently now, don't we? So what have you done as Chief Exec to prepare the NHS for when this plan is published, or are we going to have to wait once it's published more time so that you can then prepare how to actually get it done?
So as I say, we're not waiting for the 10-year plan to get on with the job. And it's worth saying that some of the things that we're talking about are about how we build on the work of the last few years, and it is how we do then the new and radical shifts that have been, the new and radical initiatives that have been, some of which we've already covered. But to take the 3 shifts in turn, the shift to community, if we're talking about what we're doing that's building on, actually a lot of the work of the last couple of years has been about putting some of the basic infrastructure in place, particularly things like urgent community response, virtual wards, single points of access for services, the investment that's gone into primary care, particularly technology. So we now have 99% of GP practices have cloud-based telephony. We've invested in triage systems. We've invested in workforce in particular. I've just talked about that in relation to additional GPs this year. There are a number of other things which are now, in fact, we're going to write about them tomorrow in planning guidance, that we need to do clearly to continue to strengthen that, if you like, foundational work. And then the things that we would expect to describe in the 10-year plan will be about then the what is the really bold and ambitious additional steps that would turn those pieces of the jigsaw into a much more comprehensive neighbourhood health offer. So it's the both and. On digital, which is the area which I think is probably the most visible of the changes that we've been making over recent years. I think our spending on digital has gone up by about 30% over recent years on digital. That has gone into a combination of frontline digitisation, so that's particularly making sure the places have electronic health records, so they're moving off paper onto digital systems, but also then on the data infrastructure to join up the data that sits in different systems. So the Federated Data Platform has been the big thing on that, not the only thing. As it also includes things like making it easier for GP systems to talk to pharmacies and vice versa. So a range of things in that space. And then the third element of the digital investment has really been about where we've done things. And again, this probably comes into the slightly more transformational piece, where there are some big bets that we've made. One of those has been in developing the app. So now, just as an example, I think at last count, 90% of GP practices have now made patient records available on the app. So huge shift from where we were a couple of years ago. And again, all of those are the sort of foundational steps that then will allow, with the 10-year plan, hopefully not just turbocharging those, but also some really radical shifts, whether that is into AI-enabled ways of working or things like ambient technology, which have the potential to really make a difference to productivity in particular. On prevention, I think the question on prevention is always how much we're talking about primary prevention versus secondary prevention, because I think we would absolutely acknowledge that the NHS has a huge role to play in prevention, but in lots of ways we have to be a partner to others who are actually much better placed to lead prevention work in the round. So the development of ICBs and ICSs was a really big commitment a couple of years ago, so July 22, to saying the NHS needed to have the right structures in place to build stronger relationships locally, so that they were leaning on some of the expertise and insight that particularly colleagues in local government have about their own local populations and the needs of those populations, and then designing solutions that would actually work locally rather than us trying to do things just at a national level. That does mean
you're going to have to relinquish control from the centre. I mean, is that accepted in NHS England or
completely?
Not?
And actually, one of the things that I don't know if we want to go on to talking a bit about planning guidance, but one of the things...
Yeah, and in fact it's leading on to my next question.
I was going to say it leads on to that, yes, exactly.
Yeah, I'm very keen to understand what are the levers that you have to pull, but at the same time genuinely allow that devolution of power. It is going to mean letting go, and what is the appetite within NHS England to do that in a way that's meaningful?
Yeah, so our, I think, view on this is I hope, consistent with what you'd expect me to say, which is nobody is better placed to be able to respond to the needs of local populations than local leaders. They know their populations, they build local relationships. It has to be done in partnership, and that's between the NHS and local government, but also between the NHS and patients, between the NHS and the public, between the NHS and voluntary sector partners. So what we want to do is give a combination, if you like, of maximum flexibility to local leaders to get on with that. But the other bit of this is then accountability, because we have to have both. So with planning guidance, which, as I say, is hopefully coming out tomorrow, you will see, and the Secretary of State has been very clear about his view on this as well, a streamlined set of national asks. Therefore, with a clear intention that gives the space for local leaders to make then best use of their resources locally and agree with local partners, as I've just said, how they best spend those resources to get the best possible benefit for local patients.
Yeah. Financial leads in the NHS will also say perhaps a more realistic view of what they can actually deliver with the money that they've got. But we've got further questions on finances that will come later. I just want to come back to actually the 10-year plan. What, from your perspective, given that you're in charge of, it's not an organisation, it's an organism,
yes, very much so,
which is enormous. What do you want to see out of that 10-year plan to help drive that transformational shift that will be different to what we've seen before? Because we've seen many such plans over the last few decades. What do you need out of this plan in order to make it really meaningful and deliver that change, not say you're going to deliver the change and then actually it doesn't happen?
So I would say there is three things and then some key enablers. So I think actually a plan that does set a very clear vision, which is been co-designed and built bottom up as the way it is being done at the moment. Huge engagement and real engagement. So there is not a secret plan just waiting to be revealed. It really is being developed as part of a true engagement exercise, but then setting out a very clear vision for patients, for the public, for staff. But secondly, it is the roadmap that sits behind that then allows us to be very clear what the steps are that will turn that vision into reality, particularly over the next few years. But the big thing that I would like out of this then is stability and certainty, so that we can all see that is where we're going. We know we've got a plan, and aligned with that, we've got a spending review settlement. That means people know what their resource allocation is that they're planning with, and we've got a clear period of stability for local leaders and national leaders to get on with the job. Key enablers, I would say, if we're talking about why have some of these shifts not happened in the past, apart from the obviousness of a global pandemic, there are, I think, 4 that I would highlight. One is the estate. So particularly if we think about the state of community estate, that's one of the reasons why 100 million additional funding is going in this to primary care estate to support that this year. But the state of the estate will be a key enabler. Technology and the continued development of not just the tech in individual parts of the system, but the join up and particularly the data sharing. The third key enabler will be workforce. So we have a workforce plan that was produced, a long-term workforce plan that was produced under a previous government. That is due to be refreshed this summer in line with the 10-year plan. That will be really important. And then the final one is going to be about financial flows and making sure that we have a system which is then designed to support that ambition and that roadmap, such that if we are shifting activity into the community, as everybody is completely committed to doing so, the money follows the patients, and we can make sure that that is then embedded in the way that we work.
That will be music to the ears of this committee, I'm sure. And just on that note, I want to clarify what I said earlier. It wasn't Parliament, but it was at NHSE that gave that quote, but it was specifically on the PAC report, so I do apologise for that. So just very finally, the streamlined guidelines, I know you can't comment specifically on them because they haven't been released just yet. But do you feel, having seen them presumably, that balance is achieved with half? I mean, it's been trailed that it's something like half the number of targets. But my understanding is that planning guidance is not what's measured, that's separate. And presumably what you'd be expecting is more localised targets from the ICBs and the ICPs. So, you know, we have a plethora of targets. Any local leader will say that there are too many for them to ever be accountable for. And then the things that they have to measure on top of that means that they're spending so much time doing that and not doing their actual jobs. Is there, planning guidance aside, the approach to targets at an even more localised level? How can you provide leadership to make sure that leaders are leading, not counting?
Yeah. I mean, I think we would agree with the distinction you've just drawn between sort of targets and transparency. So the NHS produces huge amounts of data. Sometimes that is actually quite difficult to penetrate because it is quite complex, and I think there is more work that we should do. We've undertaken to do this on how we make that data easier for the public to understand and more to turn the theory of the transparency into the really easy to access transparent data about what is happening. I think it's essential that we continue to publish data on what is going on so that local scrutiny can take place, particularly around the things that matter locally. But what we're trying to do is distinguish between that, and we'll continue to do all of that work, and the things where we have said there are now a smaller set of streamlined national asks. I mean, it's really important to say,
that's a budget-setting exercise, really. So the national guidelines will sort of set the core of the budgets for the ICBs, and then they get to have more flexibility about what they deliver around that. But that will not take away from transparency, which is a different endeavour, which I would say we would support.
Yeah. So on the budget setting, the other thing we're doing, and we might want to talk a bit more to Julian about this in a moment, but is reducing the number of things where there is ring-fenced funding. So
reducing.
So there is more flexibility for local leaders to spend their budgets on the range of things that they're being asked to do and to make those decisions locally. So there is a bit of tension here, and it's worth being transparent about that, because quite understandably, there is a desire to see particular things that people care about written into national guidance, and often to see ring-fenced funding around that. But as you say, if you're a local leader, the risk is if you have lots of different targets and lots of different pots of money, that makes it very difficult to make some of those local decisions about actually how you do things and how you prioritise more difficult. And it does reduce the flexibility that you have to address things in a way that make most sense to your local population and to your patients. So we are trying to get the right balance now of setting some things out that are national must-dos, reducing the amount of ring fences so that local leaders then have more flexibility to work out how they respond both to that national set of targets and to the things that matter the most locally. I mean, again, worth saying though that, if just because something isn't written in planning guidance doesn't mean it's not important, and it doesn't mean the work won't happen. So if I could just pick up one example, because it's been in the media in the last couple of days, women's health.
Yes.
Which is something, unsurprisingly, the committee won't be surprised to hear that it's something I care about quite a lot personally. But women's health is a priority for the government. It is a priority for the NHS. We have 39 of 42 ICBs that have women's health hubs now. It is a priority we've set out explicitly in the elective reform plan. We've got regional leads for women's health now. We didn't used to have that before, so each region has its own lead. We're working on things like a new specification for endometriosis services. We've done work on some of the policies and information available around women's health. So, for example, there's a national baby loss policy, national menopause policy. We've rolled them out within the NHS, so as an employer. We're not going to stop caring about all these things or stop working on them, whether or not there is something explicit written in planning guidance.
Okay, thank you. Jen Croft.
Thank you, Chair. And just to follow a little bit more on the kind of the issue subject of ring fencing and what appears in the planning guidance, I'm just interested as to what you feel your approach to the planning guidance is and how that kind of ensures that historically overlooked populations when it comes to healthcare don't continue to be so.
Yes, thank you. I think the ring fence issue, I think, is, I really recognise that people have different views on this, and it is, we have had times where we've had lots of ring-fenced funding to try and drive progress in certain things, and I think it's in line with the shift of your direction, Chair, that at the moment we're really clear we want to actively shift to a more local, devolved leadership arrangement within the NHS and stronger partnership locally. And the only way we're going to do that is by giving people more freedom and flexibility on how they spend their money and what they do. Saying that, I think this transparency point for us is then a bit of a safeguard. So, for example, we now publish data on inequalities as a core part of the data that we look at nationally and what we expect people to look at locally. So if we are, just to take one example, looking at elective reform, waiting lists, we publish that data nationally, not just on total numbers, but cut by inequality, so that you can see whether there is disproportionate access for people from particular backgrounds or from deprived populations. And we are choosing, where we have the opportunity to do so, to prioritise our initiatives around inequality. So the Further Faster 20 work, which is the Get It Right First Time team working with those trusts to tackle those with the longest waiting lists, where we've got the biggest inequalities challenges, is just one example of that. So I think trying to mainstream the data and therefore the focus on inequalities within all our policies has been the approach that we've been trying to take, rather than ring fencing funding around specific inequalities initiatives. was that what you meant? Sorry, I might have slightly misunderstood the question.
Almost. I think I'm interested as to whether your approach going forward is to remove ring fencing in general in the planning guidance.
Right, sorry. So I've gone right into the detail of something completely different. My apologies. Yes, in principle, that is the approach we are now trying to take. There are some exceptions to that. So really importantly for this year, we're retaining the mental health investment standard.
For this year, that was interesting.
So for this year and for next year.
Okay.
So sorry, I'm not preempting planning guidance because I know the Secretary of State has said that to this committee before.
That's right.
But that for next year, that ring fence will remain, and there are a few others. But as a direction of travel, we are trying to reduce the number of things where there are specific ring fences.
And would you be able to provide a list of existing ring fence spend as opposed to what it will look like going forward?
So I mean.
Yeah, well, I mean, as when we publish the planning guidance, and we can work out then writing to you, we can set out what has been ring fenced this year and what's been removed, and what has been removed and what is ring fenced for next year, and you'll be able to see the difference.
We'd be keen to follow that through because the consequences of that may be interesting over time.
I would just say, as a point of principle, I wouldn't say all ring fence funding is bad. But I think it is a question of choosing when and where it is appropriate to do it. And I would use the example of targeted lung health checks, where we have provided ring fence funding in order to drive a programme of work that we know improves early cancer diagnosis, saves lives, and we focused it on areas where we know there have been high health inequalities, and we have seen a change in the early cancer diagnosis rate, the first, since we started really measuring the early cancer diagnosis rate, and we've seen a narrowing of health inequalities as a result. I think it's a question of being very careful, choose when it's appropriate, but we are going to reduce the total number of ring fences.
Would you not feel that there is an appropriate case to be made then for ring fencing women's health, if we look at that in the specifics? And the Women and Equality Committee identified pervasive misogyny in the healthcare system, and is there not a case to be made that that's perhaps some way to go to addressing this? I understand what you said about measuring inequalities and having that as a measurement standard across localised healthcare. Is there not a risk that we are very aware that there is this problem of pervasive misogyny, and the solution to that is ring-fence spend?
Shall I start on that? But I'm sure Duncan will want to come in, because Duncan actually leads for women's health in NHS England. So can I first say I agree with you on misogyny. I think we're really clear that there is a big cultural challenge within the NHS, and the work of the committee has been really helpful in shining a light on that. So there are lots of, I've given some of them specific initiatives that clearly we're supporting, which speak to some of the very particular needs that women have and the things they have told us are priorities. So particularly around things like endometriosis diagnosis and care, particularly things like very at the moment, the experience people can have of having multiple different appointments in multiple different places before they can get to a proper multidisciplinary assessment treatment plan, and therefore the commissioning specification is an important part for us of responding to that and saying, no, we know we can do this better and we have to, but that isn't going to address the bigger challenge, which is a cultural one about an NHS that's largely speaking been built initially by men and doesn't always have, I think, the needs of women at its heart. So for us, things like having the regional women's health leads, the women's health network of senior clinicians and leaders working together to look at how you make every part of the service more responsive to the needs of women is the other really big part of what we need to do. And I think, I'll let Duncan speak for himself, but again, it's sort of working out for us what are the best levers to do that. And sometimes, I agree with Julian, ring fencing funding can be a very powerful lever, but that tends to work best when there's something really quite specific we're trying to fund and do differently. I think our sense with this is a much bigger challenge, and we'll need to use sort of different approaches to try and make real change happen here. But Duncan?
Yeah, and look, I'd also just say how important this is to me. I'm the head of of a profession which is 90% female. So this is really important that we get this right for women and girls. And I guess just to say that the women's health hubs, one in every ambition to have one in every ICB, as Amanda said, 39 out of 42 so far, but actually we've got more women's health hubs than that, over 80, because actually the example that has given has meant that ICBs have locally taken that and expanded the services they've got. So I think one of the things that's really important in the work that we do is to share the successes of these initiatives, to make sure that local decisions around investing in those and taking those forward are there. But we've also got lots more to do on this. I think it's really important to recognise that this we've got a long way to go. And as Amanda said, some of the work that we're doing about how do we provide really good national leadership on this. So we've got our first national clinical director now for women's health championing this, supporting the champions that we have across regions, across ICBs to really lift the profile of this work, and also about how do we make sure we've got better information for women on things like the NHS website, where we've got over 100 more pieces of information on a whole range of areas around women's health, from contraception to heart health to periods, and also tools to help make decisions around that as well.
Thank you. I just want to pick out on just one little thing. You said there's a health hub in pretty much every ICB. There is an ambition to have one in every ICB area. Is there not potentially a risk that if you remove this ring fence, ICBs that aren't doing that work, that don't have a hub, they may opt to put their funding somewhere else? And I think that you speak to a cultural issue, and I think we all know the cultural issue is there with this underlying misogyny. If you look at it on a micro, on a local level, there's still funding decisions that are being made that are inherently male. Is this not one way to ensure that 51% of the population does not continue to be overlooked?
Well, I think two things. I think one is to recognise that all of our services are caring for women and girls, and so actually one of the things that we've been doing nationally is to make sure that we bring together not just the women's health programme, but also all of the elements across NHS England, so be it cardiac, be it cancer care, to bring those together to actually make sure that we are focusing on the needs of women and obviously other groups as well. But I think that's one way, is actually bringing that leadership together. I think the other thing just to say on women's health hubs, if I give you an example of Tower Hamlets Hub, which has actually reduced the number of women requiring secondary care from 85% to 26% through the hubs. I think it's a really good example of actually why wouldn't you do this? Why wouldn't you kind of for other ICBs to start adopting that? So I think the fact that we've had some ring-fence money this year to demonstrate the impact enables us then to make sure we are spreading the information, the success, so that actually others can then adopt it.
Okay, thank you. Greg Stafford.
Thank you very much, and I would declare an interest, as previously having worked for NHS England. Let's go back to the 2% productivity that I think you say we're going to achieve by 28-29. Can you just give some outline of how you're going to achieve that, and how is that reflected in your financial and business planning?
Sure. So it is worth saying, just to kind of rehearse a bit of the productivity story, clearly a big drop as we went through COVID. The ONS data published for 21-22 does show quite a sharp recovery, but not back to pre-pandemic levels. We have particularly, I will admit, been tracking acute sector productivity, where basically we have the best, most comprehensive data. I'll come back to that. We are now measuring, it's early days, so the data will need improving, both community service productivity, mental health service productivity. So we are looking at this in the round, and we are working with the Office of National Statistics and with York to look at how we can continue to just improve the measurement of productivity across the NHS, and in particular, how do you take proper account of prevention work, where often you are investing in something, but the output is not like sort of a healthcare treatment as a healthcare treatment avoided, which is clearly a harder thing to quote some measure. So,
sorry, can I just interrupt? So what you're saying is to get to 2%, you're going to change the way you record stuff?
No, that's not what I'm saying.
Okay.
I am saying that is the work we are just continually doing to improve both our understanding and the measurement, and to properly take account of prevention work, which is otherwise hard to capture in productivity data. So I'm just saying we are working constantly to refine it and make sure that we are not, for example, disincentivizing prevention work. Now, on the 2%, over the last, well, basically since 22, 23, 24, and now 24, 25, we have been seeing acute sector productivity recovering by around 2% a year. So it is what we are currently achieving. Year to date, at the end of whatever month 7 was, so that is October, we actually see that compared to last year, acute sector productivity is about 2.4% higher. So we are currently achieving the 2% a year goal within the acute sector. By the way, we can see there is still a gap to recovering to pre-pandemic levels. So this is like not complacent. There's still a challenge for us to go at. As we look at the next few years, our way of tackling this is to focus on continuous improvement. So we can see from the data that we can continue to improve length of stay. And when you benchmark actually mental health trust, community trusts, acute trust, you can see those who are high performing, those who are not performing so well, and we provide all of that data to trusts and to commissioners, and we are investing this year in a national sort of modernisation improvement programme focused on improvement in length of stay. We think that is one of the big drivers of the productivity hit that we have seen. By the way, we are still almost a global leader in that area when you look at international data, but we think there is further we can go at. We think there is further to go at in outpatient productivity, both avoiding unnecessary referrals. We have made big advances in that through advice and guidance, and we think there is further to go across the country. Actually, we can see the variation in sort of outpatients per clinician across the country, so we're focusing on that with clinical support, and we will continue to look at, and it comes to the kind of radical transformation of how do we continue to promote patient-initiated follow-up, so where you avoid unnecessary follow-ups. We have not made as much progress as we wanted, but we are beginning to see the data turn there. So focused areas on continuous improvement. We are improving basically the kind of use of our workforce, improved retention. By the way, retention at the moment is around 7%. That's much lower than we've had it historically. We have invested in a national retention program. Because we have seen...
Retention is higher.
Sorry, retention is higher, turnover is lower.
Yes. Mm-hmm.
Sorry, my apologies. Because we have improved basically the growth in substantive workforce, we are now driving down the use of temporary staffing. We've seen a big reduction in agency spend, about almost 40% over the last 2 years. Using substantive staffing rather than temporary staffing improves productivity. We can see that. So that is the kind of focus on the continual improvement. We have streams of work focused on improving prevention. So, increased in use of the diabetes prevention program, growth in the numbers there, improved management of hypertension, cardiovascular disease. So, and we think, that will improve productivity over the next few years by about 0.2, 0.3% a year. Uh-huh. And then the thing that will transform it over time, which we really will see come through in 26, 27, 27, 28 and 28, 29, is then the investment in technology-enabled change. So at the moment, we think we can do 2% a year, a lot through the things I've just said. But as you get into the kind of back end of this Parliament, it will be through the programmes of work that Amanda's already referred to, but like the investment in electronic patient record systems, the basic IT in providers, the federated data platform, joining up the data across the NHS.
We're going to come to digital transformation in a moment. Can I just pick up on the length of stay point you made? Are you referring there to social care?
Sorry?
Are you referring in part the length of stay point as one of the
I
key
think
drivers?
and
where does social care fit in all of this?
So look, there are clearly two issues in broad terms. One is sort of the internal NHS processes. So it is, when someone is ready, making sure within hospitals discharge notes are done, pharmacy, prescriptions provided. So there is still a job of work within NHS organisations, and we can see where the variation is to improve NHS processes. We think there is still more
we
to
accept
go
it's not the whole of it, but where does it play its part?
And
I'm trying to speed you up a bit here.
No, and then as you said, no, but I'm just saying there is some which is the NHS. Then we can see that access, in particular to domiciliary care, does impact on the ability to get people out of hospital. The previous government put about £1 billion in through a discharge fund. We are trying to simplify the arrangements around the Better Care Fund, be much clearer, jointly with MHCLG, on what the goals are for the Better Care Fund, in particular around faster discharge, fewer admissions from care homes. So there is work going on, but clearly domiciliary care capacity in particular has been an issue.
A specific point, because obviously you're putting a big bet on the digital stuff, and we're going to come to that in further questions. What I'm trying to get to is, what is social care worth to NHSE in terms of productivity? And do you have a number for that? And if you don't, could you write to us?
We could write to you with at least a number on that.
We'd be very, very keen to see it. As you might be aware, we've got an inquiry on this, and this would be very helpful to the work of the committee. I thank you. Back to Greg Stafford.
Yes, and just carrying on from the Chair's point, putting aside the digital transformation, which we're going to talk about, I think, in a minute, what else are you going to do that's a radical transformation programme? Because a lot of what you've just said seems very steady as she goes. We're going to do a little bit better at this, a little bit better at that. To get to real productivity increases, surely there has to be a massive transformation of the way the NHS runs itself. And I haven't really heard much about that. I mean, does it help that you've still only got an interim director of transformation at NHS England? Why have you not got a substantive director of transformation?
Well, we can come on to the particular role, and Amanda can pick that up. But actually, technology is the thing that will announce some absolutely radical change in the way the NHS works. Through the development of the app, we'll be able to put more of the information and power in the hands of patients themselves. We'll be able to give them better guidance. It will in future be possible for them to link up their own health data in real time, even on through the sort of classic wearables. It will be possible over time for people to be able to track, I think, whether, what is actually going on with patients outside of sort of hospital conditions. Amanda mentioned sort of things like ambient voice documentation, the use of large language models. We have just run a large-scale trial with NHS England and in conjunction with Great Ormond Street, looking at its use in primary care, ambulance services, acute trusts. And we can see that today could make a massive difference in sort of clinical productivity and the reduction of time clinicians spend on admin tasks. And
all of this is really interesting to the committee. We'd love to see numbers. Yeah. So please write to us later. Yeah. All of these works are fascinating to us, but we really want some... You're giving us great examples, but we want to see the numbers behind the examples.
It's worth saying we think of the kind of 2%, by the time you get to the back end of the Parliament, that should account for around, with the appropriate investment, about around half of the change year on year.
Okay.
So, just going to be very clear. So, why don't we have a substantive director of transformation? I mean, I think Vindavak is a great guy, but why is he not the substantive director or someone in his place? Doesn't that not give a message to the sector that actually transformation isn't as important as you suggest it is?
Shall I take this one? So thank you for saying what you have. I think we're incredibly lucky to have Dr. Vin de Walker as our interim lead for transformation, because he, for those of you who don't know him, is a paediatrician and also a real expert in this area, so brings that clinical focus along with a deep understanding of what it takes to deliver change, as well as a really ambitious programme around all of the things Julian's just said, the getting on with the job of putting the basics in place and the innovation. So all the things we've just talked about, those innovations, of course, have happened under his watch, but also thanks to our fantastic predecessor, Dr. Tim Ferris. The opportunity clearly now, particularly with the new government in place, is to make sure that between us and them, we're confident that we've got the right leadership arrangements in place across NHS England and the department, so that we're aligning with the vision from the 10-year plan and really being able to be working, as I think Secretary of State said to you before, we're really working as one team at the centre of the NHS and making sure we have the right complementary skills across the piece. But for me, that strength of clinical leadership is absolutely one of the things that makes NHS England best placed to do its job, which is really support the NHS to deliver. And it's great to have Duncan alongside me today, but having Vin as one of the senior colleagues is another huge asset.
So were you hinting there that there's going to be another reorganisation of NHS England?
We just completed a very, as you probably know, a very substantial reorganisation, bringing 5 organisations into one. We've reduced the headcount of NHS England by 35% as a consequence. It was a very difficult and long process. I've been on the record thanking my colleagues at NHS England for their patience and professionalism through that. I'd like to say that again if I may. But we are very clear that what we now need to do is not another big top-down set of changes, but we do need to continue to do the work where we look at making sure 2 things. One, that we are really aligning around the priorities of this government, so that is both the today things as per planning guidance and the 10-year plan, but secondly, that we are also continuing to make our organisation work as effectively as possible to support the NHS, so the operating model, and that includes looking at where we can work even more closely with the department, as well as where we can devolve more out to ICBs and others. So no big top-down reorganisation, but definitely a process of continually looking at how we do, frankly, continue to bear down on the centre so that we are releasing funds out to the NHS and working effectively as we can.
I need to move on, please. Joe Robertson.
Yeah, good morning. Thank you. The NHS has obviously received a funding increase of 10.6 billion of additional money, but clearly there are some additional costs in there which will have to be met through inflation and pension contributions and national insurance contributions to the extent they're not sort of rebated. What assessment have you made of how much that 10.6 billion will go towards simply meeting increased costs?
So much will hinge on the pay settlement, but if the pay settlement were in line with our evidence to the pay review body, where we've said we can afford a 2.8% pay settlement, that would cost about £3.8 billion. The ENIX pressure is worth about £1.6 billion. We know that the kind of non-pay inflation that we see based on Treasury forecast is worth about £1.9 billion, and then you have what we know will come through of the kind of cost of new treatments and medicines, in particular those improved by NICE already agreed, or we can see are in the pipeline. And again, that sort of adds about £500 million worth or so of pressure a year. And then clearly we're already in negotiation with the GPs on a new funding deal that adds about £0.8 billion. I mean, that does consume most of the £10.6 billion that you just discussed. So that
that's 8.6 if we were adding it up correctly. Is that about right?
I think the 3.8 plus the 1.7. Sorry, let me just quickly do the maths, which is the ENIX pressure this year.
Countdown begins. Yes.
Yeah. That gets you to just about 5.5. The 1.9 gets you to about 7.5, and the others get you the point. And it's another 1.3 on top, so that's about 8.8. So, as I said, it then depends what actually happens on the pay deal, normally kind of basic demand growth in the NHS is worth about £3.5 billion a year. It's worth about 3%. So clearly it doesn't cover that. So that is where this year the real focus has been on us working out what we reprioritise within NHS England, what we can do in terms of reducing our own costs, plus clearly there is not a lot of new investment that will be going into new transformation programmes because we can't afford it, and then it is a real focus on productivity within the NHS and the recovery that we were just talking about with Mr. Stafford.
Thank you. The Secretary of State has also said that raiding the capital budget to fund day-to-day spending in the NHS won't be permitted under new rules. Are you confident that operational costs will be met this year without raiding the capital budget?
In 24-25 this year? Yeah. Well, there is no plan. The Treasury will not agree that to do any capital to revenue transfers, so yes. There is no plan to switch capital to, further capital to revenue to meet cost pressures this year.
I mean, given that there has been raiding of the capital budget, and I'm not seeking to sort of make criticism of that in this question, but given that that has been happening sort of long term, how confident are you that you can meet the Secretary of State's requirements that this stops in the future? Perhaps you could just say something about that.
Well, we will live with all the pressures and recognising all the extra funding that has come in to meet things like pay deals. We will live within the NHS budget this year. Our responsibility is to set a plan for next year that lives within the money voted by Parliament. That is what we are doing. And it's absolutely the straightforward thing to say is it's incumbent upon us to do it. I mean, next year, almost as we have just discussed, as you went through, yes, £10.6 billion coming in, but a lot of that goes on meeting sort of just, sort of basic cost pressures. It does not go to fund lots of new activity to meet basic demand. So there's a real focus on driving productivity. That is not easy. We have a plan to do it. And clearly it limits to some degree the amount of new investment you can put into things you really do want to go further, faster on, like technology or some of the things around prevention. But that's the set of decisions with the Secretary of State we've made, and when we give planning guidance, it is with a view to us therefore having a plan and a budget that match up and that we can live within the total funding.
Thank you very much. Anybody else?
Thank you. My section is on digital transformation, which has been highlighted as quite a major plank in delivering the sorts of changes that are needed in the health service. One of the three major shifts is from analogue to digital, and arguably the other two shifts also hang quite importantly on digital transformation, as you've discussed. It's been discussed for quite a while, we should say, electronic patient records, digitising the NHS, getting rid of the fax machine. Apart from spending a bit more money on this, what will NHS England be doing differently in practice to actually deliver transformation as opposed to just talk, as we've had previously in the health service?
I'll start, but then I'll let Julian come on. So I think, I guess we would point to at the moment, I think that additional investment unlocking genuine productivity benefit as being one, important piece of evidence about why this is not just talk. So the whole conversation we've had about productivity I think brings to life the fact that this is about us both doing more of what we are already doing, because we are already delivering that 2% this year, last year, but really saying that continuous improvement approach will keep getting us quite a lot, particularly over the next year or so. But if you look to the longer term future, it absolutely will be critical that we've got the benefits from technology starting to come through even more strongly than they are already. I should add actually that one of the other reasons why we really welcome the focus on maintaining capital funding as capital is that is another critical enabler of productivity in the longer term. It's also a disabler of it. If you don't keep backlog maintenance up to date. I'm sorry, I know this is a bit of an aside, but we think it's a drag factor on productivity at the moment of potentially even up to about 0.5%. So the ability to have that as ring-fenced funding is hugely welcome. But back to your point about transformation. So we know that places with a mature EPR tend to have, on the evidence collected so far, productivity that's about 13% higher than other trusts. So actually putting the money in to enable everyone to have a decent EPR is a hugely important building block of everything else. We've got about 90% now in place. There's a few more that still need the work done over the next year. But then the second big thing, and I think, again, any colleagues who work in the NHS will really recognise that, is then the joining up of different systems. So there is a lot of wasted time at the moment in re-entering data between different systems, logging on to different systems, manual transfer of data, which is also brings risk.
I think you're clearly outlining the problems of the system, which I completely agree with. I suppose my question is, what structurally, culturally, organisationally will be done differently by NHS England? You've now subsumed NHS Digital. From the centre, your leadership role, what will be you practically doing, apart from what I've heard so far is it's kind of a bit more of everything, like just doing a bit more, moving the dial a bit. On
do you mind if I keep going? I'm sorry, I'm conscious of time, but I'm just trying to build up, I suppose, just the layers of this. So there is a bit of, and it's just really important because I absolutely understand that some of this does, and we'll get to it, is about radical transformation and what we can do differently. But just to make the really obvious point, we cannot do the really exciting change stuff if we haven't got the basics in place, because you can't.
I guess just to challenge that, my next question, in Hartlepool at the moment, they're rolling out robotic surgery, they're using AI in MRI scans. Why is it fair? I mean, you said it's not possible. Why is it fair that in a system like that, someone has access to quite radical transformation and digital innovation, but if you're in Hartlepool, you do. If you're in Hillingdon, you don't. Again, what's the centre's role in driving that? Surely it's not just about EPRs, because a lot of systems do have EPRs now, as you've said. It's
90%, yeah. But we do have to finish the job, and there's still a job of work to do that makes sure community trusts and mental health trusts also have that basic EPR coverage. So actually, I agree with you completely. From an equity perspective as well as a productivity perspective, we actually do have to finish the job and make sure everybody has the basics in place, so that everyone can then
delivering
benefit
the
from the
10-year
next
plan,
bit.
switching the health service from analogue to digital involves getting the last 10% of trusts onto EPRs. It doesn't sound like the transformational vision that is in the 10-year plan potentially.
Sorry, I'm just saying that's the foundational layer. If you don't do that, you can't do the rest. It's like we can have cherries on the cake, but if you haven't got a cake, we're only eating cherries. So the building block is finishing the job on frontline digitisation. That isn't just acute trust, that has to cover mental health, community, and there's a big job in primary. Primary care is well covered, but it's then my second point, which is the connectivity between those systems. So if you really want to drive productivity and change, we need to stop people having to re-enter data lots of different times in lots of different systems. So the second big thing we are doing, and the FDP was a new thing, it's one of the biggest procurements that we've done in the public sector, I think certainly in the NHS, and that was last year. So that is already paying back in some of the ways that we can see trusts are able to do things like better manage waiting lists, so much more efficient waiting list management, patient flow, which is one of the things Julian was just talking about. But that cannot be a thing on its own. We also need to do things like continue the work we've done to connect pharmacies to GP surgeries to secondary care, so that secondary care can, for example, prescribe straight to community pharmacies. That connectivity layer is the next key building block. Then the third bit, which is when we get onto the more transformational, and I agree with you, much more exciting stuff. We have got brilliant examples across the NHS now where those things are in place, of people showing what you can do with real innovation. So the third big bit of this is then spreading that across the NHS so everyone.
I guess my question that I asked 5 minutes ago was how and what will you be doing to do that?
So it is specifically then the app. So I'm on my third layer, continuing developments on the app. So the priorities at the moment are continuing the rollout and the investment in the ability for patients to manage their own appointments and have much greater connectivity. So it's not just being informed about what's happening, it's changing appointments, being informed about appointments, having genuine two-way communication. It's also things like proxy access, so that you can manage care for children, older people through the app, etc. So loads more things that we can do with the app. It is secondly things like use of AI. So we've got pilots in place where we've, back to some of the stuff Julian was saying, AI supporting the writing of discharge summaries. So for junior doctors at the moment, in Chelsea and Westminster, there's a pilot going on which is allowing AI to write the discharge summaries. Now, if that works, that's something that we will then nationally support being rolled out much more widely across the NHS. But we've got to test that it's safe first, and we've got to work out how to do it. So that is a good example of something that's going on. Julian's just talked about ambient voice technology. We've just done a big pilot of that at the moment. We would really like to do that now in primary care at scale. And those are the sorts of, we could go on, and there are loads of other specifics, but those are the kinds of things that we now, if our role is to sort of support and sponsor those things to happen, so that we can do the learning, work out how to do them at scale. And then you're absolutely right, our job is to support the NHS to learn from, and the Secretary of State's phrase, isn't it, best of the NHS to the rest of the NHS.
Yeah, it might be worth reflecting on what that role is, because I've not really heard compellingly what it is to drive pace and transformation. But so when will the NHS be paperless? When will pagers, fax machines and mountains of letters going between primary and secondary care be a thing of the past? Is there a date where that will be achieved?
I think many previous Secretary of States have made commitments about being paperless. Almost all of them have ended up regretting making a specific commitment on that, not least because what's turned out to be true is it's much more complicated than, I think, just doing the secondary care side. It's back to the connectivity point. So at the moment, I think we don't have a specific timeline of investments and developments that would allow me to say to you, we've definitely got it cracked by this particular date.
No specific date for that.
But I think what we will be able to do, and hopefully this will be part of the roadmap that sits behind the 10-year plan, is set out much more clearly what the next few years will look like in relation to these to the technology development and rollout, so that we would then
apologies for rushing. I guess it's just, is there a date? There isn't a date in mind. I appreciate the context, but I'm just conscious. I've got 2 more points before I finish, I think in 2 minutes. Neighbourhood working is obviously crucial to the future of the NHS. You've talked about the interoperability between different parts of the health sector, or the lack of in digital infrastructure. We've heard it ourselves when we recently heard about health checks and the lack of data flows between local authority commissioners and providers, and real issues in service provision. So in terms of data sharing, in terms of patient records, electronic patient records, will that expand to primary care? Will that expand to community care settings? Is there any plans in place for that? And I think the Hewitt review also called for a minimum data sharing framework for the health and care service. Are you committed to that?
You want to pick this one up?
So GP practices are already well covered by electronic patient record systems. We will complete the sort of implementation of EPRs into our major trusts, and I include in that community trusts by March.
Sorry to rush you. I'm not asking about trust or about GPs. I'm asking about broader primary care and other community healthcare settings. Is there any plans?
Our community trusts do lots of our community services, and we have clearly done a lot of work and will continue to do a lot of work of, for example, joining up community pharmacies with our acute trust and GP practices. So there is a programme of work. There is a lot more that remains to be done. Yeah. And with joining up the app, so you are joining patients up with the trust and their GP practices all through one mechanism. So my answer is yes, that is the programme of work that is going on. And as Amanda said, the data platform is absolutely about how we join the data up. We continue to work with local authorities. We have data sharing agreements with 152. Yep. We have a specific team who meet with local authorities and indeed the public health providers.
Is there a commitment for a minimum data sharing framework with all ICS areas I think the Hewitt review recommended it. So do you think that has happened? Is that still to happen?
We are putting in place the sort of... There is a common framework, there is common legislation. I mean, it's complicated, but there is common legislation. The point of trying to join up the EPRs is us setting consistent set of data standards that makes it easier technologically to do it. So that work is sort of underway.
Sounds like you're describing a framework.
Yeah.
Right, good. Josh Ventington.
Thank you. I'm going to focus mainly on the shift from hospital to community, which is one of the other major shifts. Firstly, so Darcy outlined that since we'd said that we wanted to shift from hospital to community in about 2006, so this is like multi-government failure, we've gone from 47% of the NHS budget being spent in hospitals to 58% of the NHS budget being spent in hospitals. What's that going to go down to?
So I think your analysis is spot on. The Darcy review was really clear about this. That's why the long-term plan in 2019 set out clear ambitions to shift. As we know, we had COVID. But that is why in the last particularly couple of years we have disproportionately put money now back. It's the start of it. It's not the end, but we have started to do exactly what I think you're asking for, which is to see that change. There's a big I think just for a second, there's a big job of work around financial flows to make sure that as we move work, the money follows, and also that we're properly, I think, recognising, as Julian's point, the value of prevention activity and then ensuring that the funding follows that as well. At the same time, what we clearly do not want to do is take funding from acute trust, which then just means that there's an impossible ask on trying to do the elective backlog, which is still crucial, and deal with the needs of patients coming through the front door, particularly through urgent emergency care. So it does have to be a bit of a balance, and I think this is where, at the moment, what we're trying to do is make sure that every year we just keep shifting and shifting.
That's why we have a 10-year plan.
But the 10-year plan... Yeah. It is the big opportunity here, and I think you're right to say that neighbourhood health is likely to be one of the big features of that. But we are not waiting for it to get on with continuing to do the work to build the foundational layers.
What's the proportion in hospitals going to go down to?
Well, as I say, I think what we would, rather than set a kind of, at the moment in January, an answer to the 10-year plan that's going to come out in the summer, I think what we're all committed to is that year on year we will need to see that change. But at this point, I think it would be, I would be speculating to say what will be the detail.
Could we expect an answer to that question in the 10-year plan?
I wouldn't want to overcommit for something that I think hasn't yet been fully, as I say, it's a huge consultation exercise ongoing at the moment. I think what the Secretary of State has said and what we would totally support is that there does need to be a roadmap or a delivery plan that goes alongside the vision of the 10-year plan. So I would expect that we will all want to see more detail in that.
Okay, so you resiled against the idea of ring fences. So I'm just going to have a quick look directly from this morning's PAC report, where it says that NHS England acknowledged that there would have been more investment and progress in enhancing community services in 23-24 had it not been obliged to redirect funding to prop up day-to-day spending in NHS systems. Is the problem with getting rid of ring fences not that we just end up fixing and keeping going the systems that are already not really adequate?
I think the thing about ring fences, as we've sort of discussed already, is actually a bit complicated. So I apologise if I've sounded like I'm too black and white on. I'm really not. I think Julian's made the point that where there are specific things that we really can see the benefit of, there is a strong case for ring fences. Equally, if we're really going to trust local leaders and move to a more devolved model, we have to untie their hands on some of this. From a national perspective, on the community and primary care investment, that is not where we have taken funding in order to reprioritise through the number of reprioritisations we've been through over the last couple of years. We have particularly had to look at some of the other funding pots that have been available nationally in order to give more funding to ICBs to use. The risk is, as you say, that within ICB allocations, which are big amounts of money, then that is where day to day the reality has been. I think over, as I say, particularly pre-COVID and then COVID, that the pressures of the acute spend have meant that there has been, in particular, I think some of the things that they would have wanted to do, and you'll speak to them directly on prevention, on other things, have been harder to find the funding to do because they've ended up having to prop up acute funding. That is why, I think unapologetically, we have been focusing on acute productivity over the past couple of years and continue to do so, as well as all of the things I've described and we've talked about in this committee so far about how we then support our acute colleagues, and I was one, ran an acute and community trust until a few years ago, to make sure that they have the tools to deliver, which are particularly about things like technology, estate, etc.
Because I've asked about left shift and you've told me about acute services, which is very much not what, not the shift that we need to see. And I appreciate we need to have the ongoing funding for left shift, but actually that doesn't indicate to me that there's a shift in resources. If you look at the prevention question, which is one of the other shifts, one of the points that's made in the PAC report is that the public health grant is going down, and it says very specifically there needs to be a shift in NHS culture and resources towards prevention. So what are we doing? And again, I don't want to hear that there's more money needed in acute services, because I appreciate the money is needed in acute services because the prevention is not being done. But what are we doing to shift NHS culture and resources, as we're going to have to do with a less public health grant, to prevention and to both community and prevention?
My apologies. I thought your question was how do we stop acute services taking up more of their share of the budget? So that's why I was giving you the answer about productivity in acutes and what we were doing to try and make sure that there was that wasn't the case in the future. In terms of I think what you are saying was just, so what are we doing then on the community shift? So some of the things we've done over the past couple of years have really been about making sure that, particularly as far as general practice is concerned, that has been about the technology investment in things like cloud-based telephony, in the ability to then put triage systems in place in workforce. So we've got all of the increase in R's roles, and now specifically the funding has gone in for up to 1,000 additional GPs this year. We've got additional funding going in for premises this year as well, to try and recognise there's a huge amount of work to do. This is not a magic bullet, but it just begins the journey. On community services, it's been virtual wards, so we've now got, I think, well over 12,000 virtual wards. So that's in people's homes, but provided predominantly by community services. It's urgent community response services, single points of access, which don't sound terribly exciting, but actually crucial, because that's about making sure the patient has the services coordinated around their needs. Frailty services, fall services. So all of these building blocks that we've been investing in over the past years. And it, in this sense, that the investment bit just means people. So it means people and tech being able to then now be in a position where we can start to join that up to begin to form something that looks much more like that neighbourhood health model. So where does technology matter in this? It also matters because it's things like being able to really understand, segment your population, understand their risk, understand their needs, and then the proactive work led by GPs, because they're the heart of this model and it's what they want to do and do every day, but with an increased focus on continuity of care. It's one of the things we're trying to do through the new contract as well, is then support that much more proactive assessment of risk, support patients in their own home with all of those services available if they do hit crisis, as well as free up time to do, and this is where those additional roles become really important as well, some of the secondary prevention work, which again I think we would all acknowledge did take a particular hit in COVID, but now it's partly incentivised through the contract, but it's partly one of the things that we're looking at contract reform to help go further, particularly CVD, particularly diabetes, which speaks to the secondary prevention point.
You talked about how we're kind of shifting things to GP, getting more efficient, better services there. Have you done any evaluation on how GP telephone triage is working?
So we're working at the moment with PCN pilots. So we've got PCN pilots that we're working with at the moment, and they are really exploring with us. It's a whole heap of things. So it includes things like telephone, how the telephone cab-based telephony is working. So they're sharing all their data with us on volume of calls, speed of response, number of dropped calls, all of that data. They're also sharing with us their experience of triage, really different systems in place
and
across
how are you evaluating that data?
Yeah, so that's ongoing at the moment, but it's a partnership approach between those PCNs and NHS England, where it's a real open book arrangement. I met with some of them, I think
Can you
it
give
was
us
just
a
last
timeline
week
on
before.
when you'd be evaluating that?
They're doing... When's the final report? I'll have to write back to you on when we'll get a final report. We're doing audit weeks once a month at the moment. It's real open book sharing, because we're also looking at the financial sustainability of practices and what it really takes to make sure that I think we all share the same ambition, which is to have a really thriving, sustainable primary care service at the heart of a neighbourhood health model. So this is the detailed work that we're doing with those partners to try and make sure that we really have understood the impact of some of those initiatives, and then we can course correct if they're not working in the way that we would want them to, or they would want them to.
On workforce, Andrew George.
Thank you very much. On the issue of workforce and workforce planning, there hadn't been a long-term workforce plan until about a year and a half ago. And I just wondered to what extent the lack of workforce planning up until that point had actually hampered the ability of the NHS to achieve the kind of productivity and efficiency gains that you're seeking. And now that it is in place, and it's going to be updated, I think, in the summer, to what extent is that likely to drive the kind of or be a source of seeking the efficiency gains that you're seeking to achieve?
Yeah, I might let Julian come in because of the link you've rightly made with productivity. The long-term workforce, by way of introduction, I would just say it has been something that I think, real cross-party support for saying we needed to have one, and that was completely right. Mm-hmm. There are 3 elements to the plan, sort of train, retain, reform. The plan was as much about, so some of it definitely reads across to productivity in relation to retention, in relation, we talked about before, sickness, really supporting our staff, which is a huge component of it. The reform bit is, though, as much, to be honest, productivity is important, but also just making sure that as the health service evolves and changes, we also have a workforce that's got the skills to be able to work in different ways. So one of the things that will be critical to some of the neighbourhood health work is going to be colleagues who have the right skills to work in community, but also more generalist skills to deal with the whole person. But do you want to pick up, Julian?
Actually, I would say in one sense also one of the real benefits of having a long-term workforce plan, and inevitably you're making assumptions about the future, some of which will turn out to be wrong, some of which will turn out to be right, is also just being able to track, have some sense of where we can see we've got problems with the workforce, and are our plans to address those issues. And I would say mental health nursing or learning disability nursing or radiographers, are they on track? And if they're not on track, are we taking action now, cognizant of what you need to do in 3 and 4 years' time? And clearly, if you don't have the right people in the right place, you will end up with a productivity problem. So that, I would say, is one of the real benefits.
Please see, it wasn't intended to be a trick question to kind of draw you down the route of just looking at it in 2-dimensional terms, purely in terms of productivity. But looking at workforce or the workforce needs and your other and clear sort of headline requirement for efficiency gain, is there not a tension between some of the policy of for example, pursuing sort of changes to the workforce and pressures on the workforce that may be counterproductive? For example, the failure to respond, as some professionals would argue, to address some clinical numbers. For example, clinically trained registered nurses to patient ratios within the acute sector is causing difficulties with retention of staff. A lot of them retiring early because of stress and other reasons. So it can be counterproductive to not address those issues, and perhaps bringing in nursing associates, sort of dumbing down standards. Is that likely to be counterproductive? On the face of it, you can see if potential superficial efficiencies might be gained from it, but perhaps in the long run it might be counterproductive in terms of the actual outcome.
So I'll pick that one up. So I think the first thing to say is that it's really important that we do set standards around safe staffing, and we've got mechanisms in nationally to direct that, because we know the impact that if you don't have the right numbers of staff with the right skills in the right place at the right time has on patients. And so we have systems and guidance in place for our trusts, our chief nurses and others to be able to set the standards around safe staffing, and I think that's really important. But it also has to be balanced with the efficiencies, reducing agency, and actually managing the overall budgets that we have and working within those budgets. I think in terms of nurse staffing, it's really important that we actually have lots of different routes into nursing the workforce. So if you think about nursing associates, for example, that has given people an opportunity to come into nursing that they wouldn't have had if that wasn't there. So this is really, having sat with many groups of nursing associates who have gone through apprenticeship routes into nursing, I think that's opened the door to many actually healthcare support workers that are working in our organisation. I think the other thing just to say is that we've got part of the reform work, and actually all the things that we've been talking about this morning will only be delivered actually if we think about some of the reforms that we need to make in terms of workforce, the introduction of an expansion of roles such as within nursing. If you think about advanced clinical practice, making sure we've got senior clinical decision makers, we retain those nurses that are much more experienced in patient-facing roles, so that's a great way of doing that. But we've also got to think about the way in which we support staff to make a cultural shift as well. So a colleague talked a moment ago about how do we do that shift from hospital to community, actually the way in which we train our nurses and think about placements. So when I was trained, I spent probably about 8 or 12 weeks in the community, very hospital-based. In many circumstances, it's still like that. So we've got to think about how do we make sure there's enough placement capacity across the NHS in community services, but also adult social care, to really drive that visibility and actually just give people exposure to the opportunities that there are working in a different setting and community. So there's a whole load of things that we have to do in the reform space, as well as make sure that we've got nurses and midwives in the right numbers in our clinical areas.
Yeah, but I mean, no one is arguing the corollary. In other words, no one's saying that you want the wrong nurse in the wrong place at the wrong time. So therefore, that, pardon my expression, but kind of management babble is kind of worthless unless you actually have something by which to measure it. And I would have thought that, the RCN and others are looking for mandated, staff to patient ratios in certain settings, and can you not see that there's a good case for achieving, if you like, better patient outcomes and therefore better productivity if you follow that route rather than sort of trying to kind of cut, the cloth within those settings?
So look, we don't set nationally ratios for nurses, and I know the RCN are, have a specific view around that. Our guidance is that actually people should use tools that are validated tools, such as the Safer Nursing Care tool, to determine locally what the staffing ratio should be, and that takes into consideration such things as the geography of the ward or department that you're working in, actually the skill mix that you need for the patient group that you have. So this is a really complex area, but I think that the key thing here is that we enable people to set the staffing numbers that they need to be able to provide care safely for the patients that they're looking after locally.
Right, and has there been any kind of study to, now you've had associates in place, you've had the opportunity to kind of look at some of the pressures within the system itself. The long-term workforce plan has been in place, only 18 months, but to kind of see whether that approach is producing productivity or counterproductivity.
I don't think we've specifically looked at the nurse and associate through the productivity lens, but what I would say is that certainly about 50% of our people that have gone on to train to be nurse and associates then go on to top up and train to be fully registered nurses, and so actually that's a really good way of increasing the flow of individuals into registered nurse roles. So actually that clearly then has an impact in terms of making sure we've got sufficient staff that we retain into our services.
Okay, thank you.
Thank you very much indeed. Deirdre Coston.
Thank you very much, Chair. And thank you very much for coming in today. I want to particularly focus on elective recovery and waiting lists, but just sort of more overview question. I guess the Public Accounts Committee, we've heard already, the Chair has said that they feel that you're complacent about the finances of the NHS, and that you don't have the ideas and the drive. The report says you don't have the ideas and drive to bring forward the changes that the government wants to see in the NHS. And for this committee and for my constituents in Ealing Southall, we need to know who to believe. It's hard to know who to believe. You're saying one thing and the PAC is saying another. So in terms of how we judge whether you do have those ideas, the drive, and that you're not complacent about the finances, how will we judge you in 12 months' time on the number of people that are on the waiting lists for operations? So how many people are you expecting in 12 months' time to be on that waiting list? How will it come down from the 7.6 million? How long will my constituents in Ealing Southall be waiting on the phone of a morning to get a GP's appointment? And how long will they wait in hospital car parks for ambulances? Because I know you said the work's already started. So what are you expecting in a year's time?
So I think you should judge us on results. I would say that's exactly the right thing to do, and that is why I know we've laboured the point a bit on productivity in this conversation this morning, because I think I would say it is the results of the last 2 years in particular that we should be looking at in order to judge whether or not we have taken this seriously or not. Clearly, this committee and others will also judge on what is in planning guidance and what is in the elective reform plan, the 10-year plan, and all of the other plans that will need to sit alongside that about whether or not that is as ambitious as you would want it to be. I have to say, as I've said before, I don't think there's any lack of ambition in the health service. Everyone I speak to is, I have to say, 100% up for it. But it is not... this is not easy stuff, and I think we are also really conscious, and the Secretary of State said this himself as well, that too many different initiatives that pull people's attention in different directions is not helpful. So actually just delivering the things we've said we will deliver is point one, but really backing the things that are going to make the biggest difference is the other big thing that we're trying to get right in planning guidance and 10-year plan and everything else. So how will you judge on core performance? We'll be setting out those standards in planning guidance tomorrow. So the elective reform plan has already said we will be at 65% achievement of the 18-week standards, that's the referral to treatment standard, by March next year. So that's a target for the next financial year. We're about 58% nationally now, so that would require every organisation to improve by 5 percentage points and then a bit more to get up to the 65%. That is on the way to delivering 92%, which is the national standard by the end of the Parliament. So we've set really clear goals around elective recovery. There's then a lot of detail that no doubt committee members will have read that sits behind that explains how we think we're going to do that, and that is a combination of doing more of what we know already works. So we have really targeted over the past 2 years the longest waiting page. So from your constituents' point of view, there was a point just after COVID where we had far too many people waiting more than 2 years for treatment. We pretty much now have none. I mean, there are a handful, literally, and they're hugely complex patients with very specific needs. We've then targeted going down to 78 weeks, 65 weeks, and now as we sit here, we have virtually halved the number of people waiting over a year, almost halved, and I think we're down to about 96% improvement on the number of people who were waiting being 78 weeks. So that's been the focus before, and again, I would say judge us on that. But the real target, and it's a big pivot for us with the elective reform plan, is now getting back to the referral to treatment standard. So that's the thing that we're now really going to be focusing on and measuring for the coming year. We're going to be setting out expectations for the other areas you've mentioned in planning guidance tomorrow.
And I guess many of my constituents in Ealing Southall probably aren't going to read that planning guidance in detail, and so they really do want to know, literally in a year's time, if they're referred for treatment, if they will, if they'll be fast tracked, if they'll get that treatment in the time required. And the big numbers that they've heard is that the 7.6 million people on the waiting list. So are you able to kind of answer those big numbers? How many people do you expect will be on a waiting list in a year's time? And what will the average weight be?
There is modelling that sits behind what I've just said to you on relation to size of waiting list, but actually all of our pardon?
Is the modelling in the public domain?
I don't think it is actually, but I can check on that, and if it is, I'll share it. We'll happily share it.
If it isn't, could we see it? I mean, it would really help the work of the committee to be able to understand the numbers you're looking at behind some of this stuff.
The thing I would the really important thing on this is actually size of the waiting list is a means to an end. The end is how long do people wait for treatment? Yeah. So that's why this government, and we completely agree with this, have said that's got to be the target. It's getting back to 18 weeks because the size of the waiting list, if I wait a year or if I wait 3 weeks, I don't really care how many other people, in a sense, are on the waiting list. What I care about is how quickly can I get seen. So that's
both related, aren't they? Like the more people on the waiting list, the longer you're going to wait.
Exactly, which is why it's an enabler, but it's not. But it's also why over the last 2 years, without seeing much of a shift, I mean, it's gone down now, of course, as you know, to the size of the waiting list, we have been able to do those big improvements in length of wait.
Could we get that commitment from you if it's not in the public domain that we get to see it? The modelling. We understand the context you've just given that's very helpful. And
yes,
it's just a model, but we'd love to see it.
As long as I could just confirm with the Department of Health that there's no restriction on sharing, then very happy to do so.
And was there a number there for how many people do you think will be on a waiting list in a year's time? As you've said, they are related, the number and the length. Do you now, are you able to tell us now what that number is? How many people
but I will confirm if that's something that we can...
You don't know what that number is now?
I do know what the modelling says, but I'm just going to double check, given I don't think that is in the public domain, that is something that is okay for me to share with the committee. And then I'm very happy to take colleagues through that. But the other thing that is worth perhaps saying in terms of elective reform is we have recommitted in that to focusing on those people whose wait is most urgent, so cancer waiting times as well. And there's a continued commitment that we have made on the faster diagnosis standard. So that is how quickly you find out that you have cancer. At the moment, I think we're at 77% against a 75% target on that. Looking to go up to 80%. At the same time, we're also targeting, which is the big headline, has been earlier diagnosis. So again, we're about 58%, 58.5% at stage 1 and 2, which is an improvement from where we were before, continuing to go up. And then we will be, so in terms of what can you tell your constituents, making, again, as per the elective reform plan, further progress on the 62-day referral to treatment target. So that is all a package to make sure that we are tackling the longest waits, the clinical priorities, and overall reducing the length of wait.
Right. Can I ask you about then surgical hubs, which are a key part of achieving this target and getting people the hip operations and the knee operations that they need? What percentage of the reduction of the waiting list and of the length of time that you're on a waiting list will be addressed by putting in place these surgical hubs? How much of the job will be done with that? I think is it 14 new surgical hubs and 3 more being expanded. What percentage will be done, and what have you got left to do? Will there be a gap that you still need to work on?
The surgical hubs are really important, and as we see through winter, they allow you to protect elective care when there's a lot of pressure on urgent emergency care. But they are a relatively small part of the overall amount of activity that happens, partly because a great deal of the elective activity that takes place, in fact about 80%, is outpatient and diagnostic. So the amount that requires surgical intervention or admission is much smaller than that. So there's a big chunk that's day case, so that's actually about 17%. The people who need overnight admission, so the much more complex cases, is smaller again, so it's about 3%. So the surgical hubs are hugely important, particularly for that small number of people that require surgery, require intervention, overnight stay. Absolutely critical part of our plan, but that's why so much of the plan, as Julian said earlier, also focuses on outpatient transformation and on expanding what we can do with the community diagnostic centres, because that's actually where the big volumes of patients are.
And the 3% that you mentioned, I expect are like more kind of complex procedures. So what's the plan for that? If the hubs perhaps, will the hubs work for those more complex procedures, or are you looking at a different plan?
Yeah, they are. I mean, so at the moment, surgical hubs and standalone surgical centres tend to work really well for surgery that's complex enough that you need to be, in a theatre and often overnight. But like the orthopaedic hub that we went to visit recently in southwest London, where you have the wraparound support of a whole hospital infrastructure, which is how the surgical hubs have mostly been developed, that does allow you to do the more complex patient, because sometimes it's not surgery that's complex, it's the patient that's complex. And so the ability to have access, for example, to high dependency or intensive care facilities does enable those hubs to do, almost all the work that is in that sort of planned that planned pathway. Certainly when we saw Southwest London, there were very few patients who were there for who needed orthopaedic surgery who could not go through the hub.
Right, and then can I just ask a final question that's related to finances? So there's two issues. We talked about ring fencing earlier, and we are looking at ring fencing the elective recovery plan and these surgical hubs. But in doing that, of course, there is the worry that we've covered earlier, that it might have a detrimental impact on urgent and emergency care. And at the same time, we're talking also about the plan will be that, just like in COVID times, we're looking at using the private sector to help us deliver some of this. So in relation to both of those, what radical changes are you making to your financial management so that you can both work with the private sector and ensure that you're making good use of taxpayers' money, and also that you're ensuring that ring fence sticks and that you're not having that impact on the acute services?
Sorry, I missed the last bit, and we're not having the impact on?
Acute services.
So clearly we have used the private sector, more than we had pre-pandemic. They do about, they're doing about 150% of what they did pre-pandemic. They've been an important part of the recovery. We have well-established mechanisms that we're not about to radically change because they work well in terms of, clear common prices across the country for paying for elective work in either NHS or indeed in independent sector provided provision. We look every year at whether those prices need adjusting depending on where our biggest needs are. For example, we've got a to go back to women's health, a problem with gynecological weights. We are looking at the price that we pay for those to make sure we are incentivising the right level of provision. We are looking at, because actually one of the areas that has been a radical change that we need to build on is the thing I said just before about much earlier on about advice and guidance, pre-referral advice and guidance, avoiding unnecessary outpatient referrals, where we have a plan. They have grown quite rapidly, but we are going to properly reflect the cost to GPs of doing that, and we will pay. We will provide them with a fee for that service because we need to see that expanded. Because actually, we think we can reduce demand going into hospitals. Witnessed the conversation about the left shift earlier. I mean, we've avoided about 1.5 million appointments this year. So that, by the way, is a radical change. So we'll look to build on that.
So
and
just
then on,
Julian, just very briefly.
And then on the sort of emergency services, we are not planning to ring fence elective funding this year. The government required us to do that previously, so that local services, we are setting goals to improve elective waiting times, improve emergency care, but it is for them to work out how to do that.
Sorry, just very briefly, you said there that you don't think that there's any changes that need to be made to the financial systems. Having looked at the PAC report, do you seriously stand by that? I know they're talking on a wider level.
Specifically on elective care, we are not planning a radical change. I think there are bigger questions we are looking at, which include, for example, should we move to paying for activity in a similar way we pay for elective activity for some of our out-of-hospital care? Because if you want to increase capacity, that is one way of doing it. What can we learn from things we have done previously where you have given to providers population health level budgets? I mean, things like GP fund holding or the accountable, where we've got models of what are known as accountable care organisations, where not to the commissioner, you give to a provider, responsibility for the budget for, let's just say people over 65 with complex conditions. And those are things we are looking at as part of the work on the 10-year plan. But those would be for kind of more radical change from 26, 27 onwards.
Thank you. Paulette Hamilton.
Good morning, all. My question, I'm going to build up to it because I think it gives context if I do that. I'm talking about winter pressures. I've been following this, I've got to say, for a number of months. And back in July, NHSE made it very clear that they had given Trust clarity over their finances for the winter, and they'd given them £250 million, and that money was between 23, 24. May have got it wrong, but note it down if I have. Then by September, NHSE then published a letter to say that they had recognised that winter was going to be a bit of an emergency and there was going to be a significant strain. So they'd given the money in July, but by September you guys had said you now recognise there was a significant strain. But nothing else seemed to come out. Then in October, the national director, which I've got to say, I've got a bit of an interest because I know her extremely well. Sarah Jane Marsh had a board meeting. She's the emergency, what's her title? The Urgent and Emergency Care Director, had a meeting. And what she said was she felt that she had concerns about the service and the resilience to deal with winter pressures this year. Again, another red flag. Then in January, the hospitals were declaring critical incidents. I felt like, as I was watching this happening as a former nurse and now an MP, that we were hitting the Titanic, knowing the Titanic, the iceberg was there, and I couldn't see what was being done to avoid it. So my first question to you guys, and I have to also say NHS providers, as well as Sarah Jane, as well as the Royal College of Surgeons, as well as ICBs, as well as the NHS providers, everybody was shouting alarm bells. So my question to you guys are, especially yourself, Amanda, do you believe that the steps taken earlier in the year to prepare for winter pressures have been robust enough to deal with the winter crisis which the department recognised back in September? Thank you.
So I think everyone has always, and we've always been absolutely clear that their NHS is under just an extraordinary level of pressure. Okay, that has absolutely been the case every month this year, not just winter, but has been particularly the case, as you know, over winter. So we did take a different approach, obviously in agreement with the previous government this year, and rather than hold funding back to give out later in the year for winter, we gave all of the money out at the beginning of the year, and therefore have been clear in planning guidance, in the refresh of the urgent emergency care plan that Sarah Jane put out in the summer,
well, Amanda,
in the planning process. There was never...
I'm going to stop you there because I want you to, because people don't understand this. if you are running a system, a service, if the service goes up by the outputs by 3.5 times more than it did last year, even though you made an agreement that is what you would give, surely there must be something in place that you can do a revision if it is needed. I'm just asking you to keep that in mind as you are answering my question.
So we have to live within the budget that we are voted by Parliament, and the call from system leaders, as I say, having been one myself, was always more certainty is helpful. So if you can tell people at the beginning of the year what their allocation is and what they've got to live with, that is more helpful than saying here's part of the answer at the beginning of the year and then giving sort of additional bits of money out later in the year when you're not expecting it and you can't necessarily use it as effectively. But that is why the team then did do, as you say, there's been a number of moments across the year where we have tried to do two things. One is help the NHS prepare as well as it can within resources for what we've always known was going to be a really difficult winter, and a lot of that has been, as you know from conversations you've clearly had with Sarah Jane, is where we've
right.
had.
I haven't seen
I'm sorry. Okay,
it's written everywhere. But I do know her.
Well, the evidence, the evidence that we have had of what has worked well in taking some of the strain off the NHS. So that has been trying to codify where we've seen things really work and then support the NHS to do that everywhere. And that, when I say what does support mean, that has been people like Julian Redhead, who's our clinical director for urgent emergency care, leading a team of clinicians on the ground in trusts under the rapid improvement programme, with the support of people like Get It Right First Time, with support of other clinical leaders, really helping in the detail of how things work, from everything from rostering plans to front door triage to helping people with flow.
Clearly, I'm just going to stop you there because they give me a limited amount of time. Clearly, it was not working. So what was done in its place to say, look, what we've always done and what Julian, whatever, was doing is just not enough. This year, because it was such a bad year, we needed to put something extra in, because the one thing I know about Wes, he wants the NHS to be a little bit more proactive in how it addresses things. So were there any discussions how we could address some of what then happened in January, the critical incidents?
So just to be really clear, I think what I'm saying is that So it was not that people didn't start planning early. They absolutely did. And all of the things that I've just said, that was a national programme of improvement. That was new for this year, and that has not stopped the pressure over winter, but it has made the difference in some areas such that we can look. Can I just get to the end of this?
I'm afraid the chair's going to stop me. When you start going off at a tangent,
I really want to talk about
stops.
delivery. So
Okay,
because actually what's happened is we have had massively more activity through urgent emergency care this year, busiest year again. And if you look at the data on 4-hour performance and on ambulance response times, that has broadly held stable despite that increase in demand, and that is because of all the things that the urgent emergency team, care team, have supported local systems to do, because the doing is always local, and it's people in A&E departments, in GP surgeries, in community care services, putting in place and rolling out more virtual wards, more same-day emergency care, more rapid response services in the community, more work to improve flow on the ground. But it hasn't been enough. Just to be really clear, we know it has not been enough.
You know how bad it's been this year.
Some of the real challenges.
You know how bad it's been this year. I'm a great person with numbers. If there were two things you would like government to hear that you'd like to see happen next year, that we don't end up where we've ended up this year, what would be those two things?
The two is a good discipline, isn't it? So the big thing that we have struggled with this winter is the combination of winter viruses. So we've had huge numbers of patients with flu, but not just flu, COVID.
The government's controlled it.
It's not, but what it is about is a real focus on the vaccination campaign.
Okay.
So where I was
That's
going
number
with
one,
that
vaccine. Number two
is vaccination. Older people, particularly, by the way, I would say children and young people, because there's real evidence if you can get to them that helps protect older people, and it's people who are clinically vulnerable. So that's my big one. And then I think number two, actually it is going to be about support for social care. Because whilst there's loads of stuff that we can do and will do, and I completely agree we need to do more on this because of the very obvious pressures on staff as well as on patients from this winter. But support for social care is going to be the thing that I think is also just critical if we're going to get particularly the corridor care people flowing from A&E into beds and then back out of hospital again. And I know we talked about that already a bit.
Right, I'm going to hand back to the chair because I did have a second question, but I went on. So, Chair, over to you, and thank you, Amanda.
Thanks very much. Thank you. I very neatly segued. I wanted to talk about social care. I just declare an interest. I'm a former cabinet member for health and adult social care for a number of years before the election. And I'm delighted to hear that you say it's critical that we support social care. I noted in your evidence to the Public Accounts Committee, you said we can't talk about health without talking about social care at the same time. And you also said in your evidence that if there's a spare pound, put it into social care rather than put it into an acute trust. So I'd just like to understand what that means to you.
So I think I'm really aware that the social care does a huge amount more that is overlapped with the NHS. So this is just for me, not trying to take away from the importance of all of that, but where there is an overlap, the two big things for us is if we really want, and this is back to neighbourhood health, to enable people to stay well and be well supported at home, then social care is absolutely critical to that. But it is then, if people are in crisis and they are in hospital, as in they've got into a health crisis, they're in hospital, to enable people to get home again requires it's hugely important that the relationships are right locally and joint working, but it's also the capacity.
Absolutely, and we all agree that, and that's generally understood. So in practical terms, I suppose I should have been clearer. What does it mean to you in actually how you're going to change things? In very, very practical terms, you mentioned the Better Care Fund. Will you put more money into the Better Care Fund, or is the review that you're undertaking, could that lead to less money going in?
Well, I'll just say next year we'll publish the details tomorrow. More money will be going into the Better Care Fund towards local authorities. I mean, we put about around or slightly more than £2 billion of NHS funding directly into local authorities.
Have you, because you mentioned very kindly you're going to write to us about the social care's value to the NHS in terms of productivity. Have you done this analysis? If we put X more into social care, we would expect to save Y from the NHS. Has that analysis been undertaken?
Well, we'll write with the analysis, which is...
Absolutely. Has it been undertaken?
So the specific analysis we'll write on that we have done is how, from the data that we see, how many patients are not being discharged from hospital because we can't get a place in a timely place in a care home or in the right domiciliary care package, and you can translate that into, if you could free up that capacity, what do we think that would mean for flow? And I think that's what
what I'm asking is
set out.
If I could be clearer then, and I appreciate your answer. It costs what, £1,300 a day to have somebody in a hospital bed. There's the figures I'm going on, they may be a bit old. If you can get people out of beds more quickly, or if they never go into beds in the first place because they're kept to living independently at home, you'd save a lot of money. Have you looked? This is my specific question, which I'm asking if you permit me.
Yeah.
Have you looked at the amount of money you could save for the NHS if you tripled the amount, for example, or quadrupled the amount you would give to the Better Care Fund? Have you done a straightforward X, Y analysis, or not?
So you would not immediately save money.
Okay.
Because...
You've done that analysis?
Because our issue right now is we have got too many people waiting a long time in an emergency department because we can't admit them to a bed. So it isn't that we would save money right now, because in fact what we'd want to do is improve performance.
Are you saying that on the basis of a financial analysis which you've undertaken?
Well, as I've just said, we've done the analysis which says, and this is not perfect, but like from the data we can see how many people are stuck, and if you could free up those beds, what does that mean for sort of productivity, and what could that mean for flow? Mm-hmm. But we would not immediately save money, because to save money you've got to shut the bed.
You'd improve services, but you wouldn't
So you'd improve
save money.
services, but you would not certainly right now we would not immediately save money because we don't think we can afford to shut capacity. To go to the earlier question from Ms. Hamilton, about how do we improve winter performance. Clearly, if we can improve discharge, what it avoids in the future is, can you avoid having to sort of build more beds? And I think that's where it's like, what's the opportunity cost if we can't solve this for the future?
Have you undertaken the analysis of the opportunity cost?
We've undertaken the analysis, which is if we can improve length of stay, yes, how many beds could we avoid building in the future?
That's a really important figure for us to have in the light of our cost of inaction
inquiry. And I
inquiry.
think that is what will come through. I will just say, as we complete the kind of 10-year plan, and what is the ambition, both through the NHS and working with local authorities, because what we do know is if you get the model right, you get people out of hospital beds faster, you also reduce the demands on social care.
And if you never have people going into hospital in the first place, then of course you reduce demands on hospitals because the social care at home is better. I just think, and forgive me, I appreciate your answer and I appreciate that you're going to be giving us figures. There is a concern out there that the NHS has never really looked at the extra cost that's required to go into social care. But if you're doing this analysis, the Better Care Fund work will perhaps prove...
It's the department who actually decide, like, what is this, the split of funding. We put about
on your recommendation,
£2 billion of NHS funding into local authorities, and that has grown in real terms every year for about the last 10 years. So, we are putting more NHS funding into local authorities. My key point is you don't immediately save money. So it isn't as if I can just say, let's put even more NHS funding in, because to do that, you actually have to shut capacity. And right now, we couldn't afford to shut capacity.
Good, thank you. So I've been trying to get to what was meant by we cannot talk about health without talking about social care. Support for social care is critical. I'm still not quite clear that critical means a lot more money going in. But I appreciate the answers you've given. I don't see how we're going to get better social care without the NHS itself contributing money and not leaving it to the DCLG or occasional settlements.
As I said, we are contributing over £2 billion a year and growing in real terms.
I'm not disputing the money you're giving. We're talking about the future needs and meeting what you say is a critical, Amanda Pritchard, as you say, is a critical need. Can I ask something else, which is about local authorities and finance settlements? And I very much appreciate what you said, because every year, as a Cabinet member, I found it, and I'm only the Cabinet member, I'm not the Director of Adult Social Care, absolutely infuriating and difficult to try and deal with the NHS, because the finance settlements for local authorities are at a very different time for the NHS. And I think you said, Julian, that you try to, and you said this in the evidence of the committee as well, that you try to give early informal expectations, but you need to know what the budget is to give a budget. Are you saying that the government is too slow to sign your budget off? Because if the situation at the moment is you're blaming the different departments of the government for not signing the budget off, which causes local authorities such problems. Are they too slow? And how, if they are, can they be speeded up?
I mean, look, clearly there are two different budgets, and I don't, the local authority budget is done through the Department for Local Government. If I was just to take 24, 25, which
Amanda,
was...
do you want to help with this bit?
No.
I can see you trying to whisper. I wonder if it might be helpful.
I was just saying, I really want to be clear that we are not trying to blame anyone for anything.
I'm not
what
trying
we're
to blame
saying
anyone
is
either.
It's just really complicated.
It is complicated.
And it's entirely, in my view, is completely essential.
You think you've sorted
that
it
there's
out?
a cross-government recognition about what the trade-offs are across the NHS and other bits of public spending, and then for us to make sure that we have got an agreed budget is necessary for us to then issue planning guidance. So it was
it's
just
a big
as simple
problem,
as,
and it has to be recognised across government. Have you made a commitment to sorting out this problem of different timings for the budgets for local authorities and the NHS? Have you actually sat down and said, we need to do something about this, and we will do something about that?
So the thing that we've definitely all committed to is trying to make sure that as much as we are able for future years, we are getting planning guidance and budgets out as early as possible, and certainly ideally pre-Christmas and in an aligned way.
Even in a perfect world, it doesn't solve his problem.
Budgets. Pardon?
Even in a perfect world, it doesn't solve his problem, right? Because at the moment, the guidance is out in time for the financial year for the NHS, but then once that's out, is that going to be in time for local authority budgets to be set?
Well, I think the point is local authority budgets come out actually before Christmas, and ideally we would at least align the timing with that. And over recent years, we have formally published later than local government, which I think is the point. We're doing everything we can to get everything agreed with government as early as we can to get it out.
What are you actually, that's helpful, but it's very broad. What are you going to be doing differently so that the 24-25 planning guidance, the 24-25 plans have already come out, and it was only, as it wasn't released by you until a week before the start of the financial year. So what are you going to do for the 25-26 guidance to get over this problem? Is it something you sit around and talk about as a real problem which needs to be cracked?
Yes, so the NAO made a recommendation which the PAC has formally now adopted to say that the Treasury, NHS England and the Department of Health should commit to getting planning guidance out earlier. We agree with that recommendation. But I think the important thing is just recognising that it does take all of us working together to land that, because it is not in NHS England's...
Us working together, who's the us?
Department of Health, Treasury, NHS England, and then clearly there is a broader cross-government process of then agreement of budgets and right round approvals for us to then communicate that formally out to the NHS.
Do you sit round, have you pulled everybody together?
Those three.
Great. Have you pulled all those people together and said this is a real problem? Do they accept it's a real problem? Have you pulled them together to do that and to take it forward to try and find a solution?
So there are extremely regular conversations that take, I mean, Julian's in them rather than me most of the time, but, you know, between colleagues to try and work through the detail of budget allocations.
I don't take that as a yes. Am I right in saying that's not a yes?
You should take as the yes the bit that says, absolutely, we have had the conversations completely collectively about the importance of getting planning guidance out earlier and getting budgets agreed earlier. But we've also had honest conversations about how complicated and difficult that is.
Thank you.
And that we do not have the ability to do that in isolation. Sorry. And nor should we.
Thank you. Dr. Becky Cooper.
Thank you, Chair, and I will be quick because I realise we are running out of time. So I suppose following on a bit actually from Ben's highlighting the different conversations you have across the different departments, I just wanted to move us specifically to finish to talk about culture. So as we all know, culture can eat strategy for breakfast. Perhaps over the decades, it's eaten a lot of strategy and perhaps several secretaries of state. So I just wanted to ask you about your impression or your sense of what the culture is in NHS England. So if I were to go and ask various members of your staff what the cultural environment was in NHS England, how would they describe it to me? And if you could be brief, that would be great.
So I've mentioned earlier that we've just completed a big, massive reorganisation, 5 organisations into one. Part of the commitment that we made to colleagues within the organisation as part of that is we would then do a proper OD cultural exercise with colleagues. We've begun that very seriously. So we've got staff survey results most recently saying that overall it's not uniformly the case, but almost in all areas things have improved since the last staff survey, so we take some encouragement from that, but it also shows we've got a very long way to go. The big challenges for us internally is 5 organisations with 5 very different cultures and 5 very different ways of working now, all in one organisation. I think it's the biggest public sector reorganisation that's happened, certainly last year. I think probably our chair was saying, I think it's one of the biggest that's happened, sort of full stop, not just public sector. So we shouldn't underestimate, and we're not, the amount of work that we've got to do within our own organisation now, not just to align processes and ways of working, but absolutely to align cultures and create a new culture for a new organisation aligned with this government's priorities and with the 10-year plan.
Lovely. So you'll forgive me, Amanda, because I have been in the healthcare sector for quite a while now, and I've heard this said a lot every time we come to change, which happens quite a lot. So if I said to you, is NHS England dynamic? Is it flexible? Is it able to change? Does it have a good relationship with the Department of Health and Social Care? Would you recognise any of these things as true?
Yeah, different answers to different bits of that. So I think we have an increasingly very good working relationship with the Department of Health. I think that feels really positive. And that is something that we're extremely keen to build on. Parts of our organisation are incredibly dynamic. And in fact,
which parts specifically would you say are dynamic? So
I think we've got some, we've talked a lot about what's going on in the Transformation Directorate today with some of the work that they're doing on AI, on the pilots of things like, ambient technology, et cetera, we've got a great team on things like life sciences that are also doing some really interesting work on innovation. I mean, it's a bit invidious to pick out specific examples.
It is, and I suppose that is invidious. So the underlying cultural dynamic of NHS England, you would say, is positive overall and is progressive and is able to respond to the very substantive issues that my colleagues have highlighted in this session.
What I honestly think is we've got some incredibly committed and able colleagues in NHS England who have been through a huge change programme, some of whom now are still it has been really hard for people, and so some of whom I think I would say are still finding it really quite hard to adjust to a new organisation and new ways of working. Others of whom are absolutely thriving on the opportunity, particularly to work with within the development of a 10-year plan, and are really excited about the opportunity to see the things that they're passionate about reflected in that plan.
Sorry, apologies for cutting you short, but I realise we're nearly out of time. So just if I think about the Messenger Review and we look at the leadership culture, what do you think is going on in terms of leadership culture following that review? Do you think that the levers are in place? And if you come back here in 18 months, do you think you'll see a substantive improvement?
Thank you. So thank you for that. Can I just commit, though, that we are really mindful that if we're trying to do work on leadership, we have to start with ourselves. So the improvement work that we're doing across the NHS, we're doing internally. So we're applying NHS Impact internally. When I talk about culture and leadership, that is why we have a formal culture and leadership programme that we are doing within NHS England. Because again, we've got to walk the walk, not just talk the talk. And it's why we did the staff survey using exactly the same questions, so we could compare ourselves to the NHS. In most areas, we're actually doing better than the NHS as overall in NHS England, but really no complacency. We've got a lot further to go. And as I've said, I know there are real pockets that feel very different. So in terms of leadership overall, for the implementation of the Messenger Review, which was excellent, there are some things that we have already done. So, for example, the implementation of and refresh of the Fit and Proper Persons test has happened. The board appraisal framework has happened. There are other things that they started, but they haven't yet come to fruition. So we've got a big package of stuff around management and leadership, including code of practice, including a competency framework, and a national curriculum for leadership and management. That's all due to come out this year, but we've been doing that in a way which has been very much kind of co-developed with colleagues in the service, as well as using expertise from outside the NHS. So they're all in train. At the same time, we've got various other practical elements, so things like refresh of some of what's happening with the National Leadership Academy. I think we've got about 23,000 people currently having some sort of contact with the Leadership Academy in our various different programmes, but definitely kind of work to do to make sure that, again, that's aligned with the new curriculum that's being developed.
Thank you. And just as a reflection on that, I think my overwhelming feeling is that every time this sort of conversation comes up, it's always the start of something. So I would very much appreciate to hear in 3 years' time, not necessarily we're going to start something or we're going to refresh something, or we appreciate we've done terrible things and now we're going to do things differently, but just a real embedded culture of this is what we've done and this is what's actually been achieved. And I think that's probably a really key part for a cultural shift.
Yeah, great. Can I suggest we do it in a year, not 3?
A year, 3, 5, that would be absolutely outstanding. Thank you very much.
Excellent. Well, thank you very much to our witnesses. Order.